We will start our Vertebroplasty webinar. It's a series of webinar moderated by the Saudi Spine Society. We will have today with us Professor Mohamed Khattab from Egypt as well. So we welcome Professor Mohamed Khattab. We would like to start our webinar today by a talk by Dr. Majed Ashour. He will give us a talk about tips and techniques of vertebroplasty and how to reduce radiation exposure. Dr. Majed Ashour, please start.
Assalamu alaikum wa rahmatullahi wa barakatuh. First, I would like to thank really the Saudi Spine Society for this invitation. And it's my pleasure actually to be with you guys today. I'm just trying to put it in PowerPoint. All right, so I'm a vascular interventional radiologist, works in King Faisal Specialist Hospital in Jeddah. This is the outline of my presentations. We're going to talk about four categories here. I'm going to start with the modalities. Now, the best imaging modality to do vertebroplasty or kyphoplasty is actually using a biplane angiography unit. It is simultaneous visibility in both planes. It is definitely will be a faster procedure, has a lower radiation compared to the others, as well as there are in the new systems that are built in a guidance software where you can actually see your needle in fluoro in an image is like a CT. Not only that, you can fuse the CT that is done prior to the images that you are doing. So this is really great. So you'll be accuracy of having easy access of the needles. The problem, of course, is availability. It's not available everywhere, and it's only in some radiology departments. Now, going back to the fluoroscopy single plane, I think this is where most of the spine surgeons use it in the OR as a portable. We do have our own single plane angiogram. It is the same, except that it takes a little bit longer time to go between frontal and lateral views. Now, in some occasions, CT is used in addition to the fluoroscopy. This is mainly if there is some complex anatomy, the spinal deformity, some instrumentation, or trying to target some anatomy deep, sometimes for cervical spine. The problem with the CT as well as fluoroscopy, it has the highest radiation among all the other modalities. Of course, the systems you can use the existing system, or there are a new built-in system where the CT and angio are built by the same company. Now, before we actually, just before, I mean, the same day, the same morning, before we did vertebroplasty, there are a couple of steps, important steps that we have to do. We have to make sure that we reevaluate the patients, the records, to confirm the levels we are treating. This is crucial. Sometimes we write something in the outpatient clinic and we forgot about it. So this is I think, important tips. Re-evaluate the CT scans to reassess accessibility, to assess the pedicle size, the angulation, and if you want to do some kyphoplasty, you have to measure the AP diameter of the vertebral body. This is again just to double check before you start the procedure or the same morning of the procedure. To plan your approach, now, of course, the best is to go transpedicular approach, but sometimes the pedicle is small or something. We have to go paravertebral. For the upper dorsal spine, we go costovertebral, and for the cervical spine, we go anterior. So plan your axis of the needle. You're going to do unipedicular, bipedicular, what kind of approach? It's very important. Patient's position in the table. Majority, of course, what we do is prone, but only for the cervical spine, patients need to be supine. And make sure that all materials and needle sizes that you need to do it are available. This is again crucial. You don't want to be stuck suddenly wanting another size that is not available there. Now, my recommendation, there's a lot of materials available in the market. Now, regarding the needles, of course, there's a beveled end type of a needle, and there is a cone-shaped needle. This goes straight. This actually, if you hammer it, it's just gonna go away from the bevel end. So it has an advantage. I like to use this bevel end. Different types of hubs, you know, they're metal, small, there could be a plastic hubs, could be big. Make sure that you use a good quality ones, that when you hammer, that is good and stands the hammering, and also it's not too big, because if you want to do multiple levels, that might interfere with your axis. Now, for the injection syringes, it doesn't matter, metal or plastic, as long as it's a good quality. Now, what's really important to decrease the radiation, try to find a kit that has a long injection tube, because that will put you away from radiation, because the highest radiation is during the injection of the cement. Now, selecting your PMA cement is crucial again. It's very important that you know what cement you are using. Its visibility, its viscosity. You don't want it to be very viscous that you cannot inject. You don't want it to be very low that you have more leak. You have to know your polymerization heat of your cement. It's very important. Now, each company, they have different kind of specification. So it's very important to know that. Positioning, I think you guys are a spine surgeon, so positioning is something that you do routinely. For myself, I do position myself with anesthesia for all the cases. We want to make sure that, of course, we don't want to strain the neck joint, the shoulder joint. We want to avoid all brachial plexuses, compression of the tongue, airways, avoid abdominal compression, all these pressure points. Now, your OR table may be flexible. Our angio table is really rigid and flat. So we look into consideration of all those things. Now, regarding the radiation using it, there is something in radiology called as low as achievable, reasonably achievable, as low as possible. So use the radiation. So if you're not actually doing a procedure, do not press in the field. Of course, protect yourself. And I always encourage people to use forceps. So use the long forceps, sponge forceps, to guide your needle where you're going to exactly angle and get the axis, and then hold with your hand and continue. But just first angulation, there's a lot of radiation to your hand, so avoid that, please. Now, uni versus bipedicular, definitely unipedicular is a better. It's definitely one axis. It's a shorter procedure time. You can do multiple levels, and even when you inject, you're going to control only one needle at each level. The only problem is maybe a little bit tricky. It requires a little bit of more training. Now, in this slide, I want you just to pay attention. All these needles, I like to definitely always use the bevel for myself. And the marker always where the bevel ends. And if you hammer, the needle will direct itself toward the other opposite side. So if the bevel side here is going to go to the lateral aspect. And this is very important to you. Now, the technique I do, to make sure that the positioning is proper. This is the most crucial thing. Get the pedicles in the middle, spinous process here. You can see the end plates, superior inferior end plates, and then start from the lateral. It could be it could be from 9 o'clock or 10 o'clock. It depends if you are using the left side or then the other side. I usually use my bevel side lateral, so the needle will, of course, move medial. And you only use the frontal flora in this position until your needle reaches the inner pedicle. So it means that expectedly that you want your needle to pass the pedicle in order for you to safely continue. So this is the position where you do cross-table lateral fluoroscopy. Now, in this case, you can see that the needle is still in the pedicle, so it's not safe to push because you're going to go through the spinal canal. So the trick here is just rotate the needle 180 degrees, so the bevel now will be more medial. So the needle will move further. You can just hammer more until you reach. Again, check again. You see it now just beyond the pedicle in the posterior cortex. Now you just only use the lateral fluoroscopy to keep hammering until you reach anterior third as well. Then you do frontal fluoroscopy to see the needle position properly, and you can do your cementoplasty. Now the injection. Now my advice is that I read local literature and see lots of leak, and I don't know why. My advice, the primary operator should look for only this. Look at the posterior cortex and just monitor any leak that comes from here or reaching towards here. Don't. Your assistant should look into the anterior, lateral, inferior, everywhere. So this is just keep concentration here. And my advice here is continuously fluoro during the injection of the cement. So you want to achieve good filling. This is an excellent example of a patient, at least 1/2 to 2/3 of the vertebral body from superior to inferior in place. This is a very good results of vertebroplasty expectedly. Just another maybe trick, I like really use the bevel needle. You can really direct without moving the needle, just hammering it simply, it moves itself away from the bevel end towards the inferior aspect here, and then you can see it. Sometimes you can see whatever you do is still, it's not nicely midline. So just turn the bevel, make it medially, inject the cement, and you're gonna have an excellent results. All right, now the problem with vertebroplasty, of course, the cement leak. If it just leaked back to the spinal canal, that's disastrous, might cause paraplegia. If you inject too much into the vein, it's going to cause pulmonary embolism, cardiac embolism, and of course, reports of a lot of adjacent vertebral body fractures. The predictors for that is actually intervertebral clefts, cortical disruption, low viscosity, and the volume. In general, 3 to 4 mLs of cement is enough. If you inject more than that, there could be a risk of leak. This is an example where you put a needle, inject, there's a little, immediately there is a leak into the intervertebral disc. Simple technique, just pull few millimeter, turn on your knob, wait a little bit for the cement to solidify and continue injecting. When you inject, you can have a reasonably nice filling. This intervertebral disc might cause, unfortunately, adjacent fracture, but sometimes it will pass asymptomatic. For venous, is very important. If you see any line going outside beyond, or a line like this, linear line, tubular, immediately flip to frontal. Make sure that this is a vein. Don't panic, don't do anything, but do not inject. Wait for a few seconds, know your cement until it's solidified a little bit. This will be solidified, then you're going to continue injection, and you're going to have good results. Posterior, this is disastrous. My advice, don't reach the edge of the posterior cortex. And if you are there, stop. Don't do anything. This is an example. We're doing a vertebroplasty. We didn't fill it. You can see some cement here. We stopped immediately, emptied the needle, came out just barely there. Probably going to go in the epidural vein, and you're going to go into the spinal canal. So stop there and don't do anything. Now, I call not cement leakage. This is actually residual cement. Sometimes you do the injection, and you can see here trickle of cement already coming back to the posterior. So don't take a risk to inject more. Try to empty whatever in the needle by the stallet. Now, you have to be at least push it all. If you cannot push it all, at least make it in the spinal canal. Don't ever please reach this. This is going to be like a nail in the patient's back. This is avoidable. Okay, just a few tips about mainly to decrease the cement leak after the kyphoplasty. A couple of idea behind it. Yeah, it might restore, but through this cavity, the decreased risks. People invented kind of polymer coils that you would do it again to support, and then also it supports the bone. The one I did not mention is that you should know your device. I'll be disaster. The spine jack here, you can see this is the beauty of or actually the height of the vertebral body is already improvement. After kyphoplasty, you can see a good improvement. The different types, vertebroplasty, the foreign body is definitely cheaper. You can do it. I've seen cases of people doing it. Do not do it. Now, using the balloon is also still there is no metal foreign body, longer procedure time, and it's expensive, of course. There are some reports metallic plants without patients. Just to summarize, you avoid doing unnecessary patients. A couple of patients refer to me and their pain. Now, review the images to help you a lot in guide procedures. Again, keep emphasizing plastic. Proper patient positioning to avoid postural positional complications. From the talk, two important things. The OR that has a poor fluoroscopy, a good time because you are seeing better. Less radiation, not compromise in this case. Radiation pro tools. Use long injection tube during the know about it, please. Continuous sleep. This is really crucial. So if you interrupt and talk and do something, I usually, when I do this, concentrate in the posterior cortex, I'm assistant, and I've done probably the largest number of levels, and in the second, safe. My last enemy of good. Just remember that. Thank you very much. I'm just going to stop sharing now.
You are muted, Walid. You are muted, Walid.
Yeah, thank you very much, Dr. Majed Ashour, for this useful talk. So we have only one question for your post-op rehabilitation protocol. Please, Dr. Majed Ashour.
Now, a post-op rehabilitation protocol is actually make sure, first of all, to start with, post-op, do not recover the patient before you know that the cement solidified. This is a very important trick also. Make sure that we keep a cement outside to make sure it's solidified. When you flip the patient, do the same kind of a technique. Make sure that they are properly put back to their beds without having a complication of any shoulder problems. And then just bed rest. I usually, in our hospital, we admit them overnight. They will stay on pain medication. We reassess them the same day and the next morning, and they go home. But in some other occasions, vertebroplasty can be done as a DPU procedure.
Thank you very much. Now, I would like to ask Professor Mohamed Khattab from Egypt to give us the talk about how to avoid malignant cement leak during vertebroplasty.
Thank you, Dr. Walid. I'm very happy to be joining this prestigious webinar and see my friends and colleagues in Saudi Arabia. And it is my pleasure to join your activities and always in progress, inshallah. my talk regarding tips and tricks in vertebroplasty and how to avoid cement leak. Of course, you can have some benign cement leak. We can call it benign because the patient usually has no complaint post-operative. As this here, you can see some escape of the cement inside the disc. You can have a tail here because you removed the needle that early before hardening of the cement, or sometimes you can have some soft tissue cement leak, as you can see here. All of this, we can call it benign cement leak because it can cause no harm for the patient. But if we have such a complication, midline cement leak with this huge amount, it can cause neural compromise, and it can affect the patient and can render his quality of life is completely far away from the desired results. Not only the cement leak in the middle, but also the vascular cement leak, which can cause pulmonary embolism. And in order to avoid this malignant cement leak, you need to check for details. You need to properly select your patient, proper planning. You need to have and apply safe vertebral augmentation techniques, and you need to properly follow up your patient post-operatively. And so we can, each item of these, we can follow to have proper results. Regarding the patient selection, which patient?
Sorry for disturbing you. We cannot see your slide.
You cannot see my slide?
No.
Why?
It's not there yet.
I'm sharing the screen. Shall I stop sharing?
Yeah, try to do it once more again, please.
Okay. Share screen. Is it clear, Walid?
Yeah.
Huh?
Yes, you can go now. We can see it.
Okay, great. So, as I said, benign cement leak can be anticipated in the patients. And I can tell you that any patients can get some cement leak, and it is benign if you have some cement leak in soft tissue inside the disc, inside the pedicle, and no harm for the patient regarding the neurological state. So it is a benign cement leak. But if it is central cement leak and it affects the neural structure and it can cause neurological deficit for the patient, I can call it malignant cement leak. Not only central cement leak, but also vascular cement leak, which can escape and cause pulmonary embolism and devastating complications of the patient. And in order to avoid such devastating complications, you need to rely on proper patient selection and the proper planning, proper safe technique for the procedure, and proper follow-up for your patients. Let us start by taking the patient selection. You select your patient with localized pain that really affects the quality of life. And your goal is to prevent further vertebral body collapse and prevent further kyphosis deformity for the patient. And be careful. It may be contraindication in some patients with active infection, in some patients with bleeding tendency and coagulopathy. And I do believe that if your patient has neurological symptoms and signs, the vertebroplasty is not the solution, because you need to decompress and you need to fix your fractured vertebrae. Regarding patient preparation preoperatively, you need to localize where is the fracture. And as we heard from the previous speakers, that we need to do plain X-ray, CT, and the MRI. Of course, in the plain X-ray, you can see mild compression in the upper end plate or the lower end plate according to the fractured vertebrae. But if it is a delayed presentation, you can see such non-union, and there is a cleft here in the plain X-ray, which can be confirmed in the CT. And the CT also can help you to decide if the posterior cortex is intact or if it is fractured as well. If the pedicle is fractured as well, if there is any non-union or presence of clefts, because all of these needs proper planning before going for the procedure. Of course, the MRI is beneficial because signal intensity in T1 can prove that you have here high signal intensity, which denotes that there is a recent trauma and there is multiple contiguous frequent fractured vertebrae can be managed by vertebroplasty. While patient positioning, as we heard, these are fragile patients. So proper positioning by the team member in the operating theater, because these patients are osteoporotic and sometimes you can have some fractures in the wrist, some fractures in the ribs while you position your patient. So very careful position, gentle management, and you, of course, you need to decide if the patient has a lot of comorbidities that you need to rely on local anesthesia, or the patient can cope the general anesthesia. Of course, it is surgeon preference. And of course, one of the most important tips and avoid soft tissue injury and avoid progression of the needle to the soft tissue, that you use rocking motion. If you are right-handed, you use by the right-hand grip, you hold the needle from the up, and you rocking motion, and by the left hand you stop it and support the needle in order not to go away inside the patient's soft tissue. And of course, you need to study the patient well, because of in such fractures, with such collapse, with presence of adjacent segment degenerations, you can need not only vertebroplasty, but you may need augmentation by percutaneous screws, or you need some decompressions. And I think this will be discussed in coming presentations. Vertebral body corbel is a safe access, and you need to target the focal lesion. You need to have, as here, homogeneous filling of the vertebral body. And you know that the vertebral body anteriorly is rounded, so you need to stop the Jamshidi needle in the anterior third, not go that far anteriorly. And regarding the cement, I rely on high viscosity cement. After proper needle positioning and application, you need to use the cement. And in order to use the cement in the proper way, you need to have a void. A void can be created by kyphoplasty, as we heard from the previous presentation, but I am against kyphoplasty. It is very expensive, plus it destroys some bone trapeculae. So you need to create void, and this can be achieved by some irrigation of saline, which can help to create some voids, remove some debris. Irrigation with saline can take this saline for biopsy. Irrigation with saline, if it is cold saline, can cause some vasoconstriction and decrease the incidence of vascular cement leak. And at injection time, you need to use vent, as I will show you in these videos. Here, this is one of my cases that I used a double pedicular approach, and you can put the needle and you can inject saline, and you can take this saline for culture and sensitivity and histopathology. This saline removes the debris. The saline, if it is cold, can create a little vasoconstriction. By this means, you decrease the incidence of cement leak. And as well, during injection of the cement, you may use the bipedicular approach and create here by doing suction vent, negative pressure. So by using the image intensifier and use the bipedicular technique and the injectors here, you can have homogeneous distribution of the cement and avoid the malignant cement leak. So you need to inject not too much. You need around 2 cc or 3 cc maximally. Meticulous biplanar fluoroscopic technique, if available, is very efficient and helpful for you. And stop when you achieve the target. The enemy of good is better. The enemy of good is better. When you achieve the target, not say, I can inject more, I can have more. Otherwise, you can have such malignant leak. And also let the Jamshidi needle for a while till hardening of the cement in order to avoid the presence of this cement tail inside the pedicle. Very simple, let the Jamshidi needle with the trocar inside till hardening of the cement for a while. And post-operatively, your patient, you need to follow him properly, because 25% of these patients may have residual pain because of unmasking of the degenerative spondylosis. So if the patient has associated some spondylosis, you can manage them as well. And post-operative infection and the new level fractures can be anticipated. So please follow up your patient properly, and you don't forget to prescribe for them the anti-resorptive or anabolics or anti-osteoporotic medications. So my take-home message, percutaneous vertebroplasty is a safe and effective if you properly select your patient, if you follow safe vertebral body access technique, and if you follow your patient post-operatively in the proper way. Thank you very much.
Thank you very much, Professor Mohamed. So we have a question for you from the audience. The volume of the saline injected and how can be done if it's uniplanar approach?
Regarding the amount of saline that can be injected, it is usually something like 10 or 20 cc, and you start by, at the beginning you found it is a little bit bloody, then become a little bit more diluted, so you don't have debris, you don't have that a lot of blood. So by this mean you can say it is enough. So you inject it and collect it back to something like closed circuit. And what is the second question, Dr. Walid?
And if it's uniplanar, do you use it if it's uniplanar?
I did it as a uniplanar technique. I inject and then resuck it again. But I do believe biplanar is much better, because during cement injection, if you can create negative suction and negative pressure in the contralateral pedicle, it can decrease the incidence of cement leak, and it can help in creating homogeneous field inside the vertebral body. Plus, really you need that the cement interdigitate with the trapeculae, interdigitate. And I think this is one of the advantages of this technique in comparison with others, because you don't destroy the trapecula inside the vertebral body. You create voids, and this cement can interdigitate with this trapecula.
Thank you very much, Prof. Mohamed.
You are welcome.
We have a question for Dr. Majed Ashour about the abdominal gases. It's always a problem. Do you have any bowel preparation, a protocol 1 day prior to the procedure?
No, we don't do actually that. If you have a good fluoroscopy images, we don't do that. Routinely, we don't do that.
Thank you very much. Now I would like to ask Dr. Abdullah Arab to give us his talk about multi-level vertebroplasty. Dr. Abdullah, please. Dr. Abdullah Arab.
Assalamu alaikum, Dr. Walid.
Alaikum assalam wa rahmatullahi wa barakatuh. As we are waiting for Dr. Abdullah, there is a question for Prof. Mohamed about the risk of saline displaced posteriorly during, if there is posterior wall fracture.
Yes, if you have posterior wall fracture and you inject the saline in a vigorous technique, and you inject it and you don't have place to collect it from the contralateral side, you may have a little bit escape of saline posteriorly. But don't worry, because we suppose that your canal posteriorly is not stenotic. You're only afraid from injection of saline posteriorly if it is really stenotic canal. Sometimes people can inject saline and a lot of amount of steroids and local anesthetic in the epidural space as the management of epidural pain management techniques. So don't worry about that, and it is not that too much to be injected really.
Thank you very much. Dr. Abdullah, now start, please, sharing your screen.
Yeah.
Yeah, go ahead, please.
Does it show up my screen?
Yes, it is.
Okay. So I just want to make it. Okay, so I'm going to present a case of awake multilevel vertebroplasty, and she's an 81 years old female, presented with a low back pain. It's a long time, got worse in the last 6 months, and at the last 6 weeks was very severe. She cannot walk, she cannot stand straight, and she cannot even lie down or sleep. No constitutional symptoms, fever or weight loss. Her past medical history, she's a known case of ischemic heart disease with 2 stents. Examination, she presented on a wheelchair. She has a normal sensation, no tenderness on her back. These fractures, T12 fractures. She was off. I started asking myself, what are the options? Big surgery, 8 levels. Third option was to do a vertebroplasty patient, her son, her daughter. The outcomes, the awake it was a quick procedure.
Presentation,
and,
full presentation, full screen, please.
Let me try this.
F5
No.
or
Okay. So we did the procedure under a C-arm, and the patient was awake, and her visual analog score system has improved from 9 to 3 out of 10 post-op. Her pain has subsided. She started sleeping well. She started walking at home. It was a day case, and she didn't need any bracing. Awake multilevel vertebroplasty, it's always a 50-50, 50% on the surgeon and the other 50 with a radiographer and a good C-arm. So if you don't have a good radiographer or a good C-arm, don't proceed with the procedure. Bilateral pedicular approach is always better than unilateral in terms of amount of cement and the angles and the coverage. And the awake multilevel vertebroplasty always need to be a speed up procedure. Patient will be in a prone position. She will be awake, or he will be awake, and they will start having breathing problems. Pain during the procedure has to be well covered by local anesthesia. And if you can have some anesthetist with you to give some sedation. Thank you.
Thank you very much. What about MRI? Do you do MRI before the doing vertebroplasty? As a question from the audience.
Usually I don't. Most of the times I don't. It's if it's a back pain and I do have the fractures in front of me, it's a back pain. It's a fracture. I see them like a fracture with no. If they don't have a radiculopathy, it's a fracture problem.
Thank you very much. Now I would like to invite Dr. Khaled Al Assiri to give us talk about cementation and the cementation and MIS technique, as well as augmentation and osteoporotic fracture as combination technique. Dr. Khaled, please.
Thank you so much, Dr. Walid. Dear all, good evening, everybody. Is the sound is okay? I'm sharing in a minute my presentation. Is the sound okay? Presentation is on?
It is good.
Okay. So I'm Dr. Khaled Al Assiri, consultant, orthopedic and spine surgeon, National Guard Hospital in Dammam. I'm happy to be between you guys. It's an honor. And I'm going to present just one of my cases that can raise a lot of question and thinking out of the box, more surgical, regarding double treatment of osteoporotic fracture. So this is a 57 years old female who presented to our spine clinic after a fall down 2 weeks ago. She sustained compression fracture L1. She was diagnosed and admitted in a nearby hospital. She was put on painkillers. They put her on thoracolumbar brace, and she was discharged. The presentation of our clinic was actually after the 2 weeks. She came for a second opinion, complaining of back pain. Her pain score was 3 of 10. There is no radiation and no neurological symptoms. So when you look to the past history, what is important to us, apart from this, what is on the screen, that the patient was on and off on a steroid that ring a bell that she may be an osteoporotic, although she is 50, relatively young, she is 57. And she had a partial thyroidectomy. So we put this in mind that she may have an osteoporosis issue. So in clinical examination, the patient was on a thoracolumbar brace. She was walking without any support, no severe pain. She had only tenderness in the thoracolumbar and lumbar region. There is no sensory loss, no weakness, and no normal reflexes. She brought with her a CT scan of the thoracolumbar spine and MRI, which is I'm showing now. And if you can see, there is a compression fracture in L1 vertebra, mainly involves the superior vertebral plate. These are the CT. I'm running one by the other. You can see there is a crack here, and there is a minimal retrobulge in the superior part of the vertebra. Her MRI also showing more information. The fracture is, there is a bright signal, so the fracture is fresh. You can see the retrobulge and the canal is intact. And if you go down, there is nothing regarding the thecal sac, and the pedicles both are intact, which is a lot of information that we need for this patient. So we were asking what to do with her, what can we advise her? So we put in mind to go at that time for conservative. And we asked you why. Patient pain score was a little bit, in lower level. She's walking nicely. She is a patient who is already have a minimal fracture, less than 10%. So we give her other option in case of worsening that she may need go for surgery. She understands. We educate her as usual for the red flag symptoms, and we discharge her and give her the appointment to follow us after 3 weeks in the clinic. So before her appointment, actually 2 weeks when she left, she came to ER with a severe back pain, and she experienced that pain for 3 days, no neurological symptoms. And our on-call, he did an X-ray, and he saw the fracture. He rang me, so I look at it, and I saw that the fracture is progressing, and almost is now the compression is around 50% of the vertebra, anterior and middle vertebral body. So we admit the patient, and the on-call also do an BMD, although it's a controversy. I mean, I don't like to do BMDs in acute fractures. Usually it can mislead us, but from the old history that we know that the patient could be an osteoporotic for the age and the medication steroids she's taking. And if you look to the T-score here, it's ranging in the vertebral body from -1.2 to -3.2. So we are discussing what is the right management for such patient. And before we think about the management, we need to think about the underlying situation. So patient with a severe back pain, no neurological deficit, so she's intact patient, she's osteoporotic, and she had a quick progression of the compression within 2 weeks. So it's an active compression fracture of L1 with a severe back pain. So at that time, as a usual spine surgeon, we look to what is our options that we have. Can we go to continue conservative? I think the thing that I mentioned before, that there is a more compression and the severe back pain is an indication to do more of a surgical interference. And if you leave such patient, they might go and fracture more. That retrobulge may go and cause a spinal canal problem. She may come worse or she had another fracture in the near future. So we take this out. So what about doing a kyphoplasty 1 level? I'm actually a fan of kyphoplasty because I was an instructor when I was doing my fellowship in Berlin. That was when the kyphoplasty came in 2004, and I was an instructor in 2006 and 2007. And we are lucky because our center is 5 to 6 cases. We do a lot of them. And by for the cement leakage, that is the kyphoplasty fracture. I'm sure of the. What about other level prophylaxis? More level and result, but in some of them they have level, and it's like I think the pathology is not so high. Most likely, the patient will take time to sagittal balance, and this is kyphoplasty. And if you look at there, is not only osteoporosis, that level will cause another increase. As a spine surgeon, if it's posteriorly and without or do some fixation of the posterior fixation, it can be out of the screw. So this is a little bit what we do. We fixation and start to shift my practice to do this for a combination, putting the cement in a healthy, but I mean, we are avoiding. So the theory of this, do the cement, make to share and actually, especially for the thoracolumbar, after the patient is young and he was on another, or even with osteoporosis, we do that. This is what we do with the fixation of that period, but we were thinking with this minimal retrobulbs there, not fixed, that's for distraction. So we open leak during the procedure. It is all theoretical. We think further research, let me say, to prove of that which one we start first. But anyway, we get used to start with the kyphoplasty level. So we do the kyphoplasty, then I do the other one, only to avoid any distraction with the fixation. By the way, the fixation isn't only fixation inside. We don't try to do a lot of correction, especially or manipulation of the screw with an osteoporotic patient. So this is the patient after 3 months. This is the direct post-op, sorry. This is after 3 months, and this is after 1 year. And I follow some of the patients after 2 years, and thanks to God, they are doing fine. We used to do in 1 level, 2 level. We did multiple level. We don't do so much of that. We do only kyphoplasty, different from patient to patient, but this is in general. So is this procedure supported? If you look to the literature, it's actually supported. There is one article was getting out in 2011 from February, which showed that 24 patients with a fracture, they combine and use this method, and all of them, they have good outcome in a follow-up of around 1 year. That's in France. And there is a paper also from China. They follow 62 patients for 2 years, and they find that even the outcome is okay. This procedure can decrease the post vertebroplasty or kyphoplasty adjacent fracture. This is published in 2015. So this is the combination. We are now do it in selected patients, and I think it needs to be looked at it. And I think it's a good modality to treat patients with 1 to 2 level kyphoplasty, especially the thoracolumbar. It's a good procedure to be conducted in a thoracolumbar area. Now, just thanks to my colleagues, they mentioned a lot of the tricks, but since I'm doing the kyphoplasty, I just want to mention some of the things that is just to stress it, so the audience can just take it home and just strict in mind. First of all, maybe some of the colleagues, they don't do MRI. Usually, I like to do MRI. It's a standard because actually this fracture, you don't know is it still fresh or not. So some of the fracture, it can stay fresh until 3 months. And how can we know that without doing an MRI? The signal changes in MRI is our proof that this fracture is fresh. I mean, so because the fracture can happen, the continuous fracture of the trabeculae with the edema presence, it can last for 3 months. So please do an MRI, make sure your fracture, especially for the old people, you look to the X-ray, you find a lot of fracture, you don't know which one is new, which one is old. So I think it's worth to do an MRI. Now, as Dr. Ashour mentioned, you need to know which system you are using. It's very important. You need to know which cement pump you are using. Is it manual or with a pressure automatic or not? What type of balloon you are using? What is the size of the balloon? There is different size of the balloon. It depends on what do you want to do. Is it short vertebra, long vertebra? There's different sizes. Actually, how do you inject? Is it with a trocar and sleeve or direct with a sleeve? And all the kits you need to know, understand by heart, so you will be familiar and no sudden complication can happen to you. One advice I give it to my colleague, that please do when you can, when you just enter the vertebra, if you can take a sample. There is in the kit usually a bone sample that you can take, because you never know if that is really an osteoporotic traumatic or could be even malignancy. If you can, it will be a good thing additive since you are in the vertebra. Now, Dr. Ashour has explained to you, good C-arm is very, very important. If you don't have good C-arm, please don't conduct the procedure. Okay, you try to go, as Dr. Ashour mentioned, from the lateral to the medial. Most of the fractures are in the upper plate, so try to direct your needle down there as here. Now, the most important thing, please, you need to think about the posterior vertebral edge. The posterior vertebral, previously when we used to teach kyphoplasty, we said it's contraindication if you have a fracture of the posterior vertebral edge. Now it's not more. We use some of the patient with a fracture in the posterior part of the vertebra, but you need to make sure that you know the procedure very well and you will not exceed your safe zone. And actually, this is here, which has a marking, is my safe zone. I don't leave. I don't work beyond that. So when I put the sleeve, both of them, I need to make sure that the sleeve is away from my zone, which is 1 to 2 millimeters from the posterior part, and make sure that you direct your balloon below your fracture edge, and make sure that the balloon size length is very important to know that the markers are outside. Otherwise, if the marker is inside, you cannot inflate the balloon very well. So make sure that the balloon is in a good position, both of them. Your working channel is okay, and the safe zone is there. Now, when you're inflating the balloon, one advice to be given that inflating the balloon is no problem. You can inflate and your colleague inflate at the same time simultaneously. It causes a void, and if you place your channel very well, it causes a void from central to peripheral, up and lateral. So you are pushing all the cancellous bone to be concentrated up to push the fracture and on the side. So this is the perfect position of the ballooning. You can do it simultaneously. So no balloon push the wrist, the part of the cancellous bone to the other side, then it will be pushed back to the balloon, so it will be in the center. So try to do it simultaneously in the same time. And the best picture if you're getting near kissing balloons. Now, please, as Dr. Prof Majed mentioned that, Dr. Khattab mentioned that, please make sure about your cement. The cement, just when you prepare it on the table, make sure that it is pasty. Okay, don't be rushed and go and inject a fluid like cement. This is one of the problems that it can leak somewhere. So make sure the cement is pasty. And this is very important. If you do the procedure, it's better to do the cementing yourself, not your colleague, even if he's experienced. And why is that? Because you will do a lot of picture and you will concentrate at the same time. You can put both of the channel, as you say here, inside, and you prepare your injecting the cement, injecting material, then you start inject a little bit here, a little bit here, but you are the one in control. You look to the screen and you look and you know. It's maybe very difficult to control your hand and control your colleague's hand. In ballooning, no problem, but I mean in cementing, I think it's better to do it yourself, one person. You do one side, maybe you don't need to push the whole side inside, but I mean little bit from here, little bit from here, but you concentrate and make sure that you are the one in control and see the screen. You need to know when to stop. You need to know when to stop the cement. Make sure that you don't need to fill the vertebra with the cement, which it doesn't make sense. The more you look to the perfection, the more maybe problem will come. The balloon itself, when it makes a void, the maximum balloon, which is a 20 mil, there's a different balloon from 10, 15 to 20, and the 21 will make a void for you around 5 to 6 cc. So don't think you're gonna inject more than this in the vertebra. If you inject in each side 2 cc, it's an excellent one. Okay, it's perfect. Then you have full the whole middle vertebra and anterior vertebra with the whole cement, but it's not our target. Our target is to be safe. And when you see the cement coming near to the posterior border, to the safe zone, please stop. Now, before you remove the channel and the trocar, please leave them until it's hard. But one thing to do, make sure that all the cement in the channel is empty and the trocar is hitting inside in the entrance of the safe zone. That means the whole channel is empty, so we don't have spikes. And keep them there. Don't move them until it is hard. Then you make sure there is no leakage. You may break the pedicle by going multiple times. So this is the challenge, is safe for the pedicle, and the cement will stay on the vertebra. So in summary, I think it's a kyphoplasty, and all of you think, and the literature say that's an effective method of treatment of the osteoporotic vertebral fracture. And to avoid actually the complication of kyphoplasty or even vertebroplasty, you need to know the tricks and tips and your instrumentation very well. Combination of kyphoplasty, minimal invasive, it's a promising method. And I think it needs to be looked at it to consider it as a modality of treatment, especially for 1-2 level fracture. The literature supported, and I think we need to do more researching, maybe head-to-head, to see if we can do it for more than 2-3 levels, or if we can do it with cement, part of that, part of them no cement. I mean, there is a window, but it's a promising treatment. Thank you so much.
Thank you very much, Dr. Khaled Al Assiri. We have a few questions for you. If you can please answer all one by one briefly. I'll give you the first question. In case of osteoporosis fracture, what is the percentage of leak in your cases, and how do you manage the leak?
Actually, I'm not saying that I don't have a leak, but not a malignant leak, as Dr. Khattab mentioned. I don't have a malignant leak in the canal. I'm so be careful about that. We learn to be, we taught to do that, but we get some leakage in the disc space, and I get some leakage sometimes in the small veins. I stop completely when I have the leak. I don't need to continue. Maybe if it is hard and I'm sure that it is stopped, I can add another cement in the same canal after it's hardening by pulling a little bit. But anyway, the main issue, if I have a leak, I'll stop. I don't have a leak in the canal, but if you have a leak in the canal, I think you need to open it and remove it.
Thank you very much. There is a few questions. We'll put them all together. First question is, can you do only vertebroplasty for your case? Second, can you do only fixation for your case? And for osteoporotic compression fracture, what is the best kyphoplasty versus vertebroplasty?
Now, I think Dr. Khattab and Dr. Ashour, they mentioned this. Actually, to be honest, there is not much difference in the outcome if you know how to do the kyphoplasty or vertebroplasty. The kyphoplasty is more safer because it causes for you a void in the vertebra. There is no pressurizing of the cement. But a vertebroplasty in a good hand, it can give you the good result. Principle is principle. So you can do even vertebroplasty, kyphoplasty. There is no issue. I'm comfortable with doing kyphoplasty, so I continue to do kyphoplasty with all of my patients. So in the outcome, there is no much difference if you stick to the principles of both procedures. This is the question number one. Question number two, as I mentioned before, doing multiple level, we did a lot, and we saw that multiple level sometimes has a high risk of more fracture adjacent level. And I remember one case that we start with L1 only, L1 and L2 with a kyphoplasty, and ended with 6 level above and 2 level below in different occasions. And as I mentioned before, it is a combination problem. It's a problem because of the cement hard vertebra. So there's a stress point on that vertebra, plus the osteoporosis, which is taking a long time to be treated. Now, the idea of combination is to decrease the stress, get the sagittal alignment as we can, and do less cement for unneeded level. This is the idea from it. The last thing that if you do fixation, we do use sometimes fixation, but if there is no support of the anterior vertebra, will be a problem. Sometimes if the patient needs maybe vertebrectomy or fixation, we use sometimes cemented screw, finister cemented screw. The only thing that fixation alone is still a weak method in osteoporosis fracture, and you will have a lot sometimes of complication. One of them is pull out of the screw on the junctional kyphosis. I hope I get the question.
Thank you very much. Last two questions. What are the inclusion criteria for vertebroplasty in spinal tumor? And if you are filling the pedicle, do you fill it from up down or down up?
I mean, for the tumor, if it's a contained tumor, this is very important. You make sure that it's not invading the canal. It's a contained, doesn't exceed the posterior edge, so it's no problem. You can do. But in this case, when you suspect tumor, you need definitely to take a biopsy. Going from up down, down up, there is no supported literature from that one. It's experience preferences. And I don't think there is a difference.
Thank you very much. Now I would like to invite Dr. Mahdi Bassi to give us his talk about upper thoracic vertebral fracture tips and tricks. Please, Dr. Mahdi Bassi.
السلام عليكم كيف الحال؟ My voice is clear? Yes, Walid, can you hear my voice?
Yes, we can hear you, Dr. Mahdi.
Okay, thank you very much. Thank you for inviting me. Actually, I'm gonna show you some of the couple cases, which is really interesting, and I want to share with you my experience with the technique of thoracic vertebroplasty. The first case, it was this patient has a history of fracture, and at the upper thoracic level, he was operated. How can I get rid of the slides here? Okay. Yes, this is a 43 years old Saudi male. He had a history of RTA involved in 2011. He was presented to one of the centers where they assessed him, and he had a T4 fracture. He was operated at that time with fixation, and also they put for him a screw and kyphoplasty at the level. Since the surgery, he started to complain of left side arm numbness and weakness with a radiculopathy, and it's ongoing. It's a continuous pain. He did all physiotherapy. He did local injection, chiropractor, Chinese needles. There was no actually improvement. So I did the examination for him. I did upper because his complaint was at the upper level. It showed that he had weakness in the cervical till T1, although his fracture is T4 and 5, sorry, which is not related to the symptoms. Some of the surgeons, they suggest to do a revision for him, but I will show you something interesting. When you look at the fracture, this is the fracture. You can see in the CT scan here, and you can see it is the upper end plate is broken. There is a kyphotic fracture. There is a shear fracture here. Also, you can see the separation of the facet joint here, the spinous process, the interspinous process. So, and you can see here in the axial cut also as well. Like there's the anterior column here has a comminuted fracture. There's kind of instability. There's also a crack here in the lamina, which indicate there could be also there is injury in the dura. That's why he had the pain. So if you look here at the X-ray, you can see the surgeon. He fixed the level above and below, and he put cement. And when you look close here, you can see there is a cement leak at the left side where he had the symptoms. So now this is confusing actually to me. The patient, he was okay till he had the car accident. Then he had the pain in the left side hand, and the level of the trauma, it was below the level of his symptoms. And as you can see here, the cement was totally, if we see CT scan here, you can see here there is no cement inside the vertebra. Most of the cement is leaking to the front and to the side. You can see here also there is cement leak on the side here. So what do you think?
Regarding, sorry, Dr. Mahdi, regarding what exactly?
this patient, he had a fracture, which was operated by cement here and hybrided by bridging fixation. And he had left hand at C71 mainly pain and radiculopathy and weakness after the surgery. So where shall we go from this point? Do you have any suggestion? First of all, do you think this fixation, what do you think about this fixation?
But still patient is kyphotic, and again, although the fracture now looks healed, but you need to evaluate proximally to see what's going on, and again, you might do an MRI to evaluate, because this level doesn't explain the C6, C7 for the patient.
Yeah. Actually, it was a coincident, the finding, because I did actually nerve conduction study from him, and it showed that it has a coincident finding. He had carpal tunnel in the left side, which is not related to his fracture. So this issue, it is different from the vertebroplasty, where the patient had the fracture and the surgery, and by one of the surgeons by mistake was planning to do a revision for him. So in this situation, now we are dealing with kyphotic deformity, cement leak outside, which I think it is asymptomatic. At the same time, he had a carpal tunnel syndrome, and our plan now to do carpal tunnel release. I just presented this case just to be careful. If you have any surgery, you have to take a further assessment, as Walid mentioned, MRI, CT scan, do nerve conduction study. Be sure what you are dealing with, and clinical examination is very important, because his symptoms is not related and relevant to his symptoms. The other things I want to mention about the vertebroplasty, especially in the upper thoracic level, is totally different than the lower thoracic and the lumbar. If you want to start with the kyphoplasty or vertebroplasty first, you have to start with the lumbar, which is with easier levels, till you master it. Then you can go step by step to the lower thoracic. Then you can go with upper thoracic level. Here there is another case. This patient is a 62 years old male. He's a known case of DM, hypertension, hypothyroidism. He had a history of repeated fractures. He had a history of osteoporosis. He presented to me. He had to the emergency with the pain 25 days with progressive pain, and there's no radiculopathy at that time. But he started to after he was coming to the emergency with weakness in the lower limbs and coda equine-like symptoms. So we did the examination. You can see there is a drop in the sensation down in the lower level. Also, as well, there is weakness in the L2 down to S1, and even the reflex is down. I mean, hyporeflexia, both sides. X-ray, the guy he is overweight, and at the same when we did the CT scan, you can see here he had the collapsed fracture at the T4. It's almost even there's no body left in both sides. There's an old fracture down here. There's a canal compromise. And if you look here at the MRI, you can see there's an active fracture here. There's a compression on the spinal cord. There's some edema here, cord edema. You can see the canal here. There's two sections. I took the one above and the one at the level of the fracture. You can see here the cord. It's almost, there is no space left for the cord at this level. So this guy, he's overweight, hypertension. He had his chest was not clear. He had the cellulitis. He had progressive weakness at that level. The time when he presented the emergency, and here now this is the critical decision. Obese, overweight guy, 25 days. He started to have a progressive weakness, and also he had cellulitis in his leg, chest like infection. So what could you do in this situation?
I think Dr. Mahdi, the most important now is the decompress of the canal, which is now the patient is having neurological deficit, which is the most important. Now there is no rule here of kyphoplasty. I think. I mean, the vertebra, if you show me before, is near vertebra plana. Vertebra plana is one of the contraindications to go to do. If you can see, I think the one which is, it's actually two fractures. One is the above, which is almost vertebra plana, and the other one which is only the upper part of the plate. So what I will do a classical posterior long posterior fixation. We try to correction and decompression, which is important to relieve the cord. They may be, I think, if the patient improve, I may go also and do vertebral. If it is possible and the osteoporosis improve, we may do vertebral replacement, which is another excessive operation that I will not recommend it if the first one is going nicely.
Actually, Khaled, the anesthesia, they told me that this guy, he is high risk, even the cardiology. I just forgot to mention that. So they give me the choice only to go one hit. And that was really the challenge. What shall I do? Just laminectomy with fusion. The guy, he had infection. I consulted the ID. The ID started treating him with antibiotic at that time. So it was really a big challenge. What shall I do in this scenario? Do you have any other suggestion?
I will go either with the short decompression of that level, and that's it.
Actually, that was my target plan. When I went to the surgery, I put the patient on the Jackson table. Guess what? That vertebral plana is opened, and I found there is a big space. I give him about 3 to 4 days before with antibiotic. His ESR CRP dropped down, and that was really a challenge. That shall I fill the vertebra or just do decompression? Because decompression by itself alone, it's going to lead with instability. And you can see there's 2 levels here. It's broken. One is complete, the vertebral plana, and the other one, the upper end plate is broken. So in this situation, it was really a challenge. And this guy, I'm planning to go only one shot and just clear. So I did minimal invasive. I did decompression here. I didn't go deep to touch that piece, the one from the vertebra here, the one that's pushing. So just laminectomy, it was really enough, and you can see the cord was pulsating. There was no active pulse or infection I saw, so it gave me more encouragement to do kyphoplasty at that level. And it seems to me it worked. This guy, he is doing well. He started to improve after the surgery, and he went home now. I hope that he will not going to catch infection, because it would be a catastrophe. I don't want to see him again. So some of the tips and tricks when you do upper thoracic, you have to have proper tools, especially the Gamshee needle. Gamshee needle, I think it's the major instrument, important instrument that you have to have it while you're doing this kind of procedure. And you can see here you have the uniplanar type of Gamshee needle. You have a double plan here. You have a diamond shape, and usually the diamond shape, it's very important if you have a patient with a sclerotic type of bone. This one I always use it if I have a difficulty of passing the trajectory Gamshee needle to the right direction. So I always change the tip. I have one of these Gamshee needle. I have both these 2 tips together, so I can change it. And you have to choose the proper size of the Gamshee. In thoracic 10 gauge lumbar, you can use a bigger one, 15. Sometimes if you have a difficulty of going through the needles, you can get even smaller Gamshee needle. You can pass it in, put a small wire, then take it out and put a bigger size. This is one of the tricks I always like to do it. It's very important to know that your trajectory, the direction. You can see here the right is the lumbar. It's more vertical, but the thoracic level, you have to go more lateral, and try to go more to the center. You see the lumbar, you can go to the lateral third of the vertebra, but in the thoracic, you have to aim to go to the middle of the vertebra. This is one of the tricks. It's very important. Beside that, if you see both of these down, the vertebra, the lumbar and the thoracic, you can see here the pedicle of the thoracic, it's more oblique. So your direction always try to aim from the top of the pedicle. In the middle here, the pedicle, the junction needle should pass, and then your end point, it has to go to the lower end corner here of the vertebra. This is the best way, because usually the thoracic, it's more weaker than the lumbar, and there is too much pressure on the upper end plate of the thoracic. It's different than the lumbar, because this one more to be in the lordosis, and the center of rotation is more posterior. The center of rotation here is more anterior, so there's too much pressure here. So if you put your cement and above the middle level of the vertebra, you will end with a leak to the vertebra, or sometimes it can go even leak anterior. So try to avoid the upper third, try to be below the middle half. Put your cement here, and you'll see while you're pushing the cement will pass on the top and the upper part with the time. But if your trajectory going more horizontal and you start to inject the cement on the top, you'll end with a leak definitely, even with the new techniques. You can see here, if you look at this picture, I like it because you can see the upper end plate here, it's more collapse here. The one down is more flat, and you can see the needle is directed down at the lower end corner, trying to avoid the upper end plate. And if you gain more of the cancellous vertebra here on the top, and you fill with the cement, that will help you to raise the upper end plate up without the cement leak. There is also an additional techniques. If you can't find the pedicle, or the pedicle is broken, you can go even from the posterior lateral or far lateral trajectory. It is similar like the in-out end technique, which we are using it in scoliosis, and this is also very safe. But as I mentioned, these techniques you have to get trained first with the lumbar, lower thoracic, before you go with the upper thoracic level. Here you can see the balloon when we inflate it. The direction of the balloon here is very important. You have to choose the type of the balloon and the pressure, because if you look here, there is too much pressure at this level. So if you have a fracture down here, then you cannot inflate the balloon to the 3 millis, because it will end with cracking that piece and pushing the upper third to the front, and then you can end with the leak to the disc here. The other things, what we're saying, the spread of the cement. Let me just take you back here on one slide. Yes, this. If you put after you put the needle and the guide, and then you start injecting the cement. First, you have to inject at the anterior half the cement on the vertebra here. Just go with 1 millimeter, 1 cc of the cement. Don't exceed. Then pull back about half centimeter, and then inject again, and then pull back half centimeter and inject. So spread the 3 in the whole in 3 steps. Don't just keep injecting, because if you keep injecting in one point, then you will create pressure solid point that can cause leaking, or even can cause more fracture to the adjacent level. Beside that, if you put the cement in one point, then it might leak backward, and it can be like a smooth surface that will end with loosening. And there is a papers that show that some loosening with the cement if you just inject it in one fixed point. So that's why we like to spread the cement, okay, and try to make it looks like a mesh and a tree shape. If you can see here, as my colleague Khaled, he mentioned, nowadays, even if there is a fracture in the posterior, we don't, it's not an absolute contraindication. We still can operate if you follow the instructions, the one we just mentioned, and my colleagues they mentioned. Beside, don't when you press the cement, don't push it too strong. Just go gentle. Spread the pressure. There is a paper that mentioned that it's better to keep a balloon from one side to prevent the collapse. But the problem, if you leave the balloon, you have to be careful, because now we are having extra pressure from one side, and you're injecting the cement from the other side. So what do we have? This is one additional information. If you have a leak inside the disc, what shall we do? Shall we stop? Shall we continue? My opinion that if there is a leak inside the disc, it means that disc has already ruptured. And beside that, it's not just only rupture. There is the progressive. It will happen. Progressive degenerative changes at that level, and you will end with degenerative disc in future. So I believe if there is some leak that going through that disc in one side, it is good because you're gonna change that disc from soft fixable to a solid one. So you're gonna avoid future surgery to deal with the degenerative disc, adjacent degenerative disc disease. Nowadays, the recommendation before it was 3, maximum 5 levels. I don't think now this is an issue. If you know the tips and the techniques and how much you fill the semen, especially with multiple myeloma, you can do it. You can do it in one stage. You can do it in 2 or 3 stages. But in the end, yes, you can do more than one level. So thank you very much.
Thank you very much, Dr. Mahdi Bassi. Now we will give you a quick talk about a fracture at the vertebroplasty level. So now this is going to be kind of fast. So this is a patient who is 60 years old, female, non-diabetes mellitus, hypertension, smoker, and obese. She sustained an osteoporotic fracture, was treated somewhere else in another region of the country outside of from Riyadh with T12 kyphoplasty. And it was, as we said, 6 months ago. She has severe mid-back pain, bilateral leg weakness, and left drop foot, using a wheelchair for mobilization for the past 6 months due to pain and progressive weakness. She is in wheelchair, kyphotic posture, mid-back tenderness. Examination showed lift more up to like a drop foot symptomatology and decreased sensation dorsum of the foot. She has an images done outside Riyadh. So she has the X-rays, which is not available now because she presented into my private clinic, MRI outside, which will not add to your clinical decision. Nerve conduction studies and EMG done as well, as we stated, because we need to have full investigation. This is her image, the MRI, the CT scan, where we can see that the posterior wall is broken at T12. Cement is broken through the upper end plate and destroy the upper end plate of 11. If we see more cuts, we can see that the cement in the right side goes even into the canal, more in the canal, and there's significant compression in the right side compared to the left side. For the sake of the time, as well as we're running late for this, so this patient presented in the private practice. He has limited insurance, and we cannot do the extremely extensive procedure for her. So we elected to do the T12 pedicle subtraction decompression and transpedicular decompression, posterior spinal instrument fusion, and cement extraction. This is the picture intraoperatively. This is the side where the cement was in the canal, where it's removed. The other side of the cement flipped longitudinally to act as anterior column, and using a funnel, we pushed more cement to fill the gap, with using monoscrews above and below to keep the structure. This is the CT scan where you can see the cement longitudinally, posterior decompression, where it's complete posterior wall and the pedicle are removed. She's 2 months post-op. She's mobilizing without walking aid, improved sagittal balance, and she's using AFO for left drop foot. This is the X-ray at the first clinic follow-up. You can see here the rib head extraction for the costotransversectomy. Still maintained the cement longitudinal position. We can see more bone integration. Still the construct maintained. 9 months again, she is still mobilizing with without walking aid and no pain. She is satisfied, but still persistent drop foot. This is her standing full sagittal balance. where again hardware is still in place without sign of failure, and the cement longitudinal as it's kept with significant posterior bone graft which is added bilaterally, and the patient is satisfied. We can argue that this patient could have complete vertebrectomy where displacement cage for level or 2, but as we said, she cannot afford this extra payment. This is a valid option. Using the monoscrew to act as significant posterior tension band and resist the torque and the for going back to kyphotic posture. And actually, she is really satisfied, and this is was good outcome for the patient, and she was satisfied. I would say that she's poor compliance patient, like we got to call her frequently, although she is a relative of a colleague, a close colleague friend. So I don't know why she missed her regular follow-up with her initial surgeon, and she wasn't really controlling her diabetes well, but at the end, this worked well for her. This is the end of my case. We can open the floor for any question for any of the speakers. Thank you for your attendance and participating. We are open for any question. So anyone would like to have any question? So anyone would like, we have one question here. What about MRI stair sequence? So this question for Dr. Assiri, Khaled Assiri. Although you said that you are not going to use the MRI routinely, as I recall, maybe Dr. Majed Ashour, what do you think about MRI stair sequence, Dr. Majed Ashour?
Yes, thank you very much. I think I do actually request MRI, not routinely, but definitely to identify the age of the fracture. As Dr. Khaled mentioned before, actually, or Abdullah, is that there are stages of fractures, and sometimes patient comes with different fractures. So stair images can show the edema in the acute fracture. So it is actually useful. I do that for the multiple. If it's on a single level, I think just CT is enough.
Thank you very much.
If you allow me, Dr. Walid, I mean, as Dr. Abdullah mentioned, I mean, it's for me and mandatory. I do all of them MRI, especially if there is multiple fracture. I don't know which one is new, and you will be surprised that one little fracture that you see it on the X-ray, it appears as a part from metastasis when you do an MRI. And we have some cases that it's only an X-ray with one little fracture, and when you do MRI, we're surprised that there is a non-fractured myths in the spine. So just be careful. I think it's an easy modality to do, and it gives the surgeon a safe pre-operative planning.
Thank you. And we have a question for Dr. Majed Ashour. How can you get a good lateral X-ray control for upper thoracic segment? Or Dr. Mahdi Bassi, anyone can answer this question?
I think I personally don't do anything above T4. I do it from T5 down, because from T5 down up to T4, you can see with the arms abducted, you can really still see very nicely until probably T4. Above that, it's a little bit tricky, but I think again, the hands has to be a little bit more in abduction down level, if as possible. It's probably better to do it somehow in a patient not in deep, I mean, general anesthesia, so that you can a little bit move in general. It's a little bit something I usually don't do actually above T4.
I do the same, Dr. Walid. T4 and down, never go above that.
Sorry.
I do the same. I do kyphoplasty or vertebroplasty in general, not above T4. So T4 and down.
Yeah, sure. One quick question, how to overcome the vertebral interosseous pressure during injection of bone cement? And what is the difference in injection with direction, tip of the needle inside or outside the vertebral body?
Maybe I can answer this question. Actually, I found, because I use the bevel and the needle, I found that the cement goes out when I use the bevel end towards the bevel end. So it can help, but to some extent. Afterwards, it's going to go to other places. To overcome the pressure, I think you cannot predict where the cement is going to go during vertebroplasty. You're going to inject slowly and you're going to see. The best thing, again, to wait a little bit for the cement to slightly to be more viscous. Nothing else.
If you allow me, Dr. Walid, to add regarding the kyphoplasty, because I'm doing kyphoplasty with a nominated pressure. And actually, the old one nominated for the balloon is around maximum 400 psi. And the new one now, they increase it up to 700 psi. So we can just when you have resistance or you reach your raising of the end plate, or you reach the maximum. I never exceed the 500 within the lumbar area, and no more than 400 in the upper area regarding the nominated balloon control. But the cement, as Dr. Abdullah mentioned, we cannot predict it. It's an experience. As I mentioned before, it's not the amount of cement you put inside, it's the satisfy amount. Not you don't fill everything that you in the vertebra.
Thank you. Now a question, general question, if a cement leak into vertebral canal, which is very rare, what is the procedure that should be carried out? We hope never it should happen. So anyone from you would like to take this? Like if you got cement leak into the canal, what you should do?
Is the patient awake or he's under GA? If he's awake and you have a sudden paraplegic patient on table, then you need to act accordingly and try to decompress him as soon as possible. We have two problems. We have the compression and we have the heat of the cement, especially if you are at the level of the cord where the canal is very narrow. You may have a long-term deficit. It will go less if you are doing a lumbar level and patient under GA, you may awake him and assess him. But if there is acute weakness, you need to react as soon as possible.
Okay, thank you. And the question for Dr. Mahdi, in case of multiple osteoporotic fracture, how many vertebrae can be cemented in one sitting safely? Any tips to do more numbers? Dr. Mahdi.
Actually, I went up to 5 levels with the vertebroplasty. But the most important thing is that you have to be sure that the level where you stop, the adjacent level shouldn't be weak, because definitely if you end with the level you put the cement and the adjacent level is weak, you would end with the fracture. So sometimes I use the DEXA and try to judge the level where I can take the weakest levels. One of the tricks also I like to do it, if you do 5, for example, and the upper level that you put the cement, try not to put too much cement, try to make it less, and try to keep the cement away from the upper end vertebra. By this way, you can have some flexible and some dynamization between the levels, and this will reduce the chance of adjacent level fracture. 5 levels, I think it's safe. More than 5 levels, I think then the troubles can't have it.
May I add a comment? Yes, I do also up to 5 levels. Usually multiple myeloma patients, I usually do multiple levels. I think what's really important is that make sure that you don't do very long procedure, because the patient will be in prone position. We know the complication rate. So try to do as much as possible, not exceeding a number that you cannot really tolerate. Or you can perform. Do the levels. I usually put, if I'm just going to do only vertebroplasty, I put all the needles and then I inject all of them one after the other.
Thank you very much. Professor Abdullah Arab is giving us a lot of nice comments. He said he did a similar case to mine where he added fenestrated screw and cemented them as well, which is a good technique. He told us as well for the above T4 navigation could help, and it's a good tool. And he commented that for any leak into canal, it should be opened immediately and the cement should be removed. So we have a question for Dr. Assiri. Is it systematic to put a long fixation with kyphoplasty after osteoporotic fracture? Again, this is a repeated question, kind of.
Actually, I do it in selected patient, as I mentioned, 1 to 2 level maximum. We saw the result is better, and our theory is supported by the literature, and our theory we see it by experience. I mean, non-injecting, non-affected level, it can decrease the fracture in future. And as I said, this is a combined modality. It's one of the options, but we may work on more research on to head-to-head between the fixation alone, fixation with kyphoplasty, or kyphoplasty more than 3 levels. So it's one of the, it's not systematic for each patient.
Thank you very much. And we have a quick comment from Dr. Niraj Jain, which is another important tips is to aspirate bone marrow before cementing to avoid pulmonary marrow embolism. Thank you, Dr. Niraj. Anyone would like to comment, Dr. Majed, Ashour, or any of the?
I don't know, but there is no study to show that this aspiration will actually benefit. I don't think, I don't know if he can give us some kind of article or reference, but it's not something that's known to do this.
Actually, I do aspirate only to send the cells as well for cytology, as well as culture. So this is I use routinely with the biopsy itself. So added to the biopsy, I use this to send the cells or aspirate for cytology and the culture sensitivity gram stains.
I do the same, Dr. Walid, only for specimen for histopathology, and to be reminded that once you puncture the vertebra from the pedicle posterior, you decompress even the interosseous pressure by puncture them even with the working channels.
Thanks very much. Again, just Dr. Niraj said that's only for multiple fracture cementing. It's okay. It's a good idea. As Dr. Majed Ashour, it's worth looking in the literature. And if you have, it's good to share it with us because we are learning from each other. Thank you very much all for this great webinar and attendance. Thank you for the faculty for this great contribution, great talks, tips, and nice cases. Really appreciate. I did learn from you, and thank you all.
Thank you so much.
Thank you, everybody.
Thank you so much.
Thank you very much.
Thank you very much.
Okay.
Assalamu alaikum.
Assalamu.
Assalamu.